Tell me a little bit about your role as a rural provider. Who do you provide services to, and what is that like here in the rural area?
Well, I take care of women of all ages. If they knock on our door, we accept them at the clinic. There's not really anybody that we turn away.
And about how big is this town? Do you know how many 100,000?
Not quite 10,000.
Yeah, 9,000.
When a high-risk baby is born and the services aren't in this area, what area do you send them to?
We go to Wichita usually, and or Kansas City.
Okay, and that's at least 2 hours?
Uh-huh.
Mm-hmm. Okay.
About 45 minutes by air.
By air.
So we have a helicopter locally that we can typically get people door to door within 45 minutes.
They usually, most of the places prefer to send the babies, once the baby is here, by fixed wing. And so the flight still can be, but the fixed wing does have to land at a distance away. It's not like they can just land at the hospital. And so, yeah, we usually consider when we're thinking about trying to get ready to transfer somebody that I usually allow, say, at least an hour and a half to 2 hours, and then if the weather's bad, it's going to be closer to 4. So you have to be thinking ahead, at least a minimum of 2 hours. So the child may look okay right now, but what are they potentially going to look like, in 2 hours? And if the question is, I don't know, or there's at least a chance that things could go wrong, you ought to be calling now, because it could be 4 hours, before. So
changes the way you're doing
it. Changes the way you practice, yes, considerably, especially when I visit with people from the big cities that are just down the road from the tertiary care center. They can sit and watch something a whole lot longer than I feel comfortable with.
So what barriers do you encounter working in rural Kansas?
Aside from not having specialists immediately available, such as high-risk OB specialists, our hospital is well staffed, but not 24 hours a day. And since we're each individuals, we don't have partners to back us up if we're here or stuck at the hospital.
Tell me a little bit about your clientele. Who do you see, and how far of a distance do they come from?
I have had people come up to 100 miles to see me. My practice just in and of itself is probably about, I would guess about 30, maybe between 30 and 40% Medicaid. The majority are Caucasian.
I think my patient population is probably closer to 60 to 65% Medicaid out of my obstetric population.
When I first came from Western Kansas in the 1980s, the thing that really struck me was we had so much higher Medicaid population here in Southeast Kansas.
We don't have a lot of growth in Southeast Kansas. We don't see a lot of immigration for job opportunities because there aren't new job opportunities. There's a lot of complacency here.
Oh, yeah.
There's a lot of complacency of, this is just how I was raised, this is how it's going to be, there's really not going to be any change.
And what are some of the barriers that you see, some of the clients that you see, or some of the patients that you see? What barriers are they dealing with?
I would say the biggest barrier for my patients is just education of when they need to be seen and what is abnormal.
So knowing some of the signs and symptoms of preterm labor, knowing
or
when to
pregnancy.
Okay. Kansas has a higher rate of infant mortality than the national average, and some of our rural communities have an even higher rate. How do you see some of the barriers contributing to infant mortality?
In terms of education, I think despite what we tell them with the risks of their behavior, they don't see the need to change, especially if they've had a previous pregnancy with a successful outcome and a baby that has lived. Even if they did illicit drugs during that pregnancy, they will always go to that specific outcome as a success and not worry about the potential risks with the subsequent pregnancy.
What are some of the most common risks that you see?
Tobacco use. We have a rather large marijuana problem, and of course, with every small town, methamphetamines.
So they've had positive outcomes and have been using or abusing illicit drugs, and so it's hard for them to see that this might have an adverse effect.
Right.
When you're trying to understand or communicate with people, one of my biggest barriers is trying to understand where they're coming from and understand how I can say anything that is potentially going to give them something positive to think or work with.
How do you enter a room and start where the patient is?
I mean, as a resident, I used a lot of medical terminology with patients. I don't hear. It's just not necessary, and I don't get anywhere. So talking about neurodevelopmental outcome with marijuana use is wasting my breath. Talking about their child not being able to graduate high school is something they understand. Or being able to go to a normal kindergarten.
It's awfully easy for me to walk into that room and say, oh, I want your child to go to college. I want them to be president of the United States. I want them to do whatever. But that may not at all be what that parent is looking at. There are many parents that will look at a positive outcome as the child didn't die. Or maybe that the child is able to finally say the word daddy. And that's okay if you understand where they're coming from, because if you can understand that, then you can work with it.